doing this for quite some time. I was originally did my training out in New York. I was originally in Jersey, and then from there I went to upstate New York and did an anesthesia residency. Followed that with a interventional pain management residency in the same location. So I'm double boarded in both topics, and I've done focused most of my time on interventional pain management. So it's an honor to be here, and I look forward to working, kind of answering questions and also going through some of the things that we have to offer to help you with some of your chronic pain management needs. I'm trying to pull up a slideshow, I think is what we got signed up here. Let me see if I can pull that up. Let's see, how does that work?
So ask if you might have to get your share. Can you share the screen so then he can show his desktop?
He should be able to share the screen. I made him a co-host.
Okay.
Here's the share. It says share. Would that be
Yes.
it?
At the bottom where it says share screen, it should give you the option of what screens to share.
All right. What do we want to share? This one? Do we click that big or it's different?
Yeah, this
Love the fancy.
okay. Something is not right, of course. It's all...
What about that share button there? Does that do anything?
No.
There we go. Now push that share button. See what that
Well,
does.
let's do.
Where's
No, he's not even on. He's off the Zoom.
yeah, let's see. Maybe
That's save, not share though.
It should be at the bottom of the screen, a green button that says share screen.
okay. Let me pull that back real quick and go back to the launch of the Zoom meeting. Where to go?
Yeah, that's what I'm saying.
Is it right here?
No, hold on.
Here. Put it in there.
Sorry, guys.
We're all learning Zoom, guys. Crash course. Sorry about that.
Good luck.
Yeah. I still remember the Commodore when it first came out.
Wasn't part of your residency?
Yeah, I was in yes, sir. I was in Jersey for a while, and I did some training with those folks at Mount Sinai, and then I went to upstate New York and Syracuse and did anesthesia, 4 years, level 1 trauma, and followed that with an interventional pain management fellowship under Sebastian Thomas. I was there with him for a year, and then I came down south after that, and that was 20 years ago almost. So more like 16 years ago. But
Okay, so now
yeah, let's see. We're working on trying to pull this thing up.
Yeah, she's trying that.
Otherwise, just go straight to the call and we'll just talk. I can talk about it. I mean, I'd love to have a slideshow for them, but if it's a problem,
yeah,
I don't want to waste everybody's time.
yeah, I think that probably is going to be the best thing because it is definitely not.
There's something wrong with that computer. It's not doing what we asked it to do. So I'm trying to figure out.
Not sharing. Well, it's not giving us the opportunity to.
We have IT around here.
No. Let's try this. Hey.
Pulling something up. There you go. Looking good. That might do it. All right. Let's see. Can they see this?
We only see a blank screen, a
Oh.
black screen.
We lost you.
Oh yeah, I'm looking at the actual PowerPoint. We got that here. Let's see what that does. Let's see if that pulls it up. Let's see if that'll do something. This keeps going to this.
Should be a gallery view on there.
Michael, tell him to turn his camera on.
I think the best thing to do is just to talk through and then we can email them the slides that they can share.
Yeah, that's fine. I mean, I guess they're probably right. I'm going to talk to you guys so we're not wasting your time. I appreciate all of you guys here. And I just want to go through some of these slides and kind of explain what we're doing. And what's that?
Yeah.
And these aren't really down. These aren't really down. I mean,
Jamie, we still have a black screen.
I have no idea what's going on.
Right, Doctor, you need to unshare your screen so we can see you.
Oh, okay.
okay, yeah, let's do that. Let's stop the share. Okay, there we go. Hey, let's just talk. I'm so sorry about that. Thanks, Meg, for trying. Basically, it's just pretty pictures that talk about what I'm going to talk about anyway. So let's just kind of go through this and talk about what pain management is and what we do. It's basically a conglomerate of multiple modalities to try to get the pain down for patients from all walks of life and all types of. We focus mostly on spine, but we certainly work also on neuropathy, different kinds of neuropathy pain, whether it's from diabetes or poor circulation. We also work on, good to see you there, Mr. We also work on various types of complex regional pain syndromes that exist from pre-existing injury. So there's a very wide range of options that exist as far as trying to take care of pain chronically. And I think one of the biggest things that we think about is it's not just one thing or another. It's not just, a bunch of pills to get it done. It's not just a bunch of shots to get it done. It's a combination of different things together that can really give us the most opportunity to decrease your pain and increase your functionality. Too often, unfortunately, what happens is a lot of good folks start taking medicines from their well-meaning doctors that they originally see that might not have been pain specialists. And the process continues and the doses continue to escalate and they still hurt and they don't get what they need out of it. And then we get them in the ninth inning where they're hurting, they're on soaring doses of medicine and they're very frustrated. So I hate seeing that for them. So it's nice to be able to really have a frank talk with those folks and try to help them create a strategy to start figuring out ways to live a more productive life without pain, without being heavily dependent on pharmaceuticals to get the job done. Obviously they have their own set of issues, but that involves things that nobody talks about. For example, one of the things we have at Optum Physical Therapy is this concept called dry needling. It's a type of it's almost like acupuncture, but physical therapists offer it, and people get so much relief. I had a retired Marine that got so much relief by just doing that. They have massage therapy, they have strengthening, laser therapy, things that nobody talks about that potentially can help with all kinds of pain. But regardless, when those things fail, we also have other options to take care of the pain. And I think to understand why those options actually work, I think you need to understand the root problem underneath what's causing all the pain. And oftentimes, for example, if it's your back, it's usually related to some kind of angry, swollen, irritated nerve, or it's caused by aggravated arthritis. It can be caused by, in the knee, obviously arthritis is a very big deal. But all those things together cause swelling. And none of these pain pills actually help the swelling. And that's the whole point behind intervention. When you can take something that, let's say your family doc gives you by mouth, a steroid, and you take a bunch of these steroid pills and you're like, well, that didn't do much, or it helped while I was taking it. That's not an answer. You want more out of life than that. So imagine taking all those steroid pills, combining them into one big ball and dropping it exactly where the problem is, whether it's your back, your knee, whatever, you get more out of it. And so you start to really directly impact the swelling and inflammation and everything else. And then by getting you a little bit more productive life, we employ a bunch of things that everybody else does too, as far as, standard interventions. You got trigger points, you got epidurals, you got facet injections. All those are good, but there's also some cutting edge stuff that sometimes when you've already been down that road and you're still hurting, certainly is nice to offer to patients who hurt. One of the things that's particularly popular as far as, for example, knee pain is this thing called genicular branch block. It just recently, I think it was in the Journal of American Academy of Orthopedic Surgeons, they just published a result where they looked at blocking the knee and even deadening the nerves around that knee with an RFA gives better relief than taking anti-inflammatories over the course of a long period of time. So, that's been a real nice addition to be able to help people live pain-free or have less pain in the knee, for example, because it's all connected. Whether you have knee pain, you start walking funny, then that affects your back because you're straining your back, then you have back pain. So it all feeds off of each other. And we want to try to break that cycle in a way that's actually, common sense oriented, but also targeted very specifically to bring down and diminish the overall amount of pain. And when that happens, a lot of my folks have been real fortunate to be able to dial down on their opioid use. The biggest problem I see is people, unfortunately, getting stuck on a bunch of high-end opioids, and then over a period of time, that causes its own set of problems. And I think a lot of people have talked about it. Affects testosterone levels, it affects bone density, immunity, and the list goes on. So I think the goal is a common sense oriented approach that incorporates a series of different options, cutting edge and traditional, that can get you the most relief. I've had these Zoom talks before, and one of the things that was particularly popular as far as discussions with this was this spinal cord stimulator idea. This is a device that, became real popular by Medtronic back in the 80s. And then basically, it took a life of its own when it actually became a practical application. When I was in fellowship, early 2000, we had spinal cord stimulators that were very archaic at the time. If you look at them now, compared to what we do now, compared to what we did back then, the iterations and generations of improvement on this device have been tremendous. But basically, it's designed to help people with pain, whether it's back and leg pain, any kind of neuropathic pain related to nerves, for example. It seems to do a good job of calming that pain down. When you do something like that, it's usually people who can't have surgery because they're too sick or have had surgery and they still hurt with back and leg. Also, certain types of neuropathies really do well with that. People who've had substantial diabetic neuropathy and, just been there, done that, maxed out on pain medicines, and they're still hurting. Well, there's got to be a way to get around that. And this is a beautiful option because it's just a trial. You try it out for 7 days and make sure you love it. If you get substantial relief during that 7-day period, then you can go ahead and get this thing buried in with an outpatient surgical procedure. It's like a pacemaker almost, but it's been a game changer for a lot of folks, and I've been real fortunate to be able to offer that. The youngest I ever did this for was an 18-year-old kid out of New York, and the oldest was 103. Just everybody, there's a wide range of people that it works for is the whole point. So it's been real nice to offer that. But again, that's really the last ditch kind of thing. There's so many other things you can do that are a lot more simple that can oftentimes contain the pain, that I just think people need to know and be aware that these things exist, because that'll allow you to make an informed choice on how to address the pain long term. But yeah, we do a lot of different things. And at the end of the day, it's all about you. It's about trying to help you reduce the amount of pain you're in and do it in a way that's safe, effective, and a long-term sustainable process. But yeah, I think, if you ever get a chance to come in and see us, we'd be honored to see you. We'd be happy to kind of guide you. If there's something I can't do, I usually know somebody who can. So it's always a win-win either way. And it just depends on, where we're at on the spectrum as far as what you've done and what needs to be done to try to help you contain some of your chronic pain issues. But with that, I'm happy to open up to questions and answer anything you guys might have.
If anybody has any questions, just unmute yourself and you can ask. David, did you have a question? I see you're unmuted.
What about having neuropathy in your feet? Is that done with this, treated with a stimulator?
It can be. And I actually have had one patient who was really taking a lot of diabetic meds and just wasn't getting what he needed out of it. And he was on high dose gabapentin. He was on high dose Lyrica. He was taking them both together just to get that burning out of the way. And fortunately for him, we were able to get that coverage, the targeted nerves covered to the point where when I saw him back after the implant, he looked sharp, dressed to the nines. And I asked him what he's doing, and he said he's going on vacation. So I was very happy for him. And he's able to dial down on those nerve medicines as well to help him. I guess the question, everybody's different how they respond, but that's the beauty of a trial. You try it out and see if it makes any sense for you. If during that week of trial, you get scores of relief, you're just very happy, and then it makes sense to get that thing put in. But that's the beauty, is you're not committed to surgery, you're committed to a trial. And if it's appropriate, where you've been there, done that, exhausted every conservative option possible, and you're still hurting, well, something's got to give. And this is a great opportunity to consider something like that.
I just started on pregabalin yesterday.
Okay.
Those 25 milligrams. How long do you give it a chance before you start looking at pain management?
I think you're doing that's so good. You're on such a low dose. You got room to play. I mean, I'd be plan Z for you at this point. I think it's one of these things where, if the medications, as they gradually and safely escalate them to therapeutic effect, they help you, and then that's fine. I get it. But the minute you feel like either you're not getting relief from the medication, or you're meeting side effects that are unwanted, or you're starting to have drug interaction with other medicine that you're on, then it makes sense to really consider this as a realistic option. But I agree with you. You're on a pretty low dose, so you've got plenty of room to adjust and see what this does. You may not ever need this, but I agree. Just maybe kind of work with the prescribing doctor and see if they can help you get this under control. But certainly the good news with what you're on is it's a pretty low dose. If you're my own family, I'd say, keep doing what the doc's saying with the pregabalin. You don't need that pain guy yet.
Thank you.
You're welcome, Mr. Harris. Pleasure.
For anybody who spent time in Syracuse, I got to give you an award.
I appreciate it. Yeah.
It's better than Buffalo.
Oh, okay. So we're neighbors. You know how that is. It was unbelievable. My fondest memory, or my most traumatic memory, was I was on call one night, and our calls go 24 hours, and this was back before anything was regulated as far as hours and stuff. So I walk out to the parking lot to look for my car. It's total whiteout, can't see anything, and I couldn't find my car at 8 a.m. So I just went back to work. Nothing else.
But understand that.
Yeah.
I think you have a question from Sharon Galen.
No, Jamie.
No, I'm having Dr. Haggerty do shots in my back tomorrow.
Oh, you're in good hands. Joe's one of ours, and he does a fabulous job. So I'm glad you're doing this.
Yeah, tomorrow.
That's great.
The name of the something that you implant?
Yeah, it's called a spinal cord stimulator. It sounds more ominous than anything else, but it's basically
Mainly for the back.
It's for back and leg, but it can also be for back. And that just recently happened, where they were able to improve the technology where it actually can help with the back pain too.
What about severe arthritis of the feet? Right, yeah.
Yeah, I think severe arthritis of the feet, I think that might actually might not work for you. In other words,
Right.
It'd probably be a waste of time. I think the best thing for severe arthritis of the feet will be to, talk to, they have a lot of new things. Like they got topicals that they can use. They can use, certain types of medicines. For example, the SNRIs like Cymbalta, big hit with arthritis in general. If you hadn't tried something like that, maybe get that family doc or prescriber to seriously look at if you're a candidate for something like Cymbalta. It's helped a lot of folks with arthritis in general.
That's good.
Yeah. Yes, ma'am.
I had the dry needle. I've also got a torn muscle in my hip.
Oh, yes,
And
ma'am.
I went to a therapist and they did the dry needle, and that helped tremendously.
Oh, good. Yeah. Like I said, when I saw that one guy, I knew about it, but, I didn't know until you actually see a patient come back and give you feedback. Everything is just kind of studies and theoretical. So he came back, this is years ago. He came back and he just said, "Doc, I have no pain. I'll see you later." I said, "Beautiful." And that was wonderful. So it does have its place. So I encourage everybody to try it, So I'm glad it helped you.
Yep. Thank you.
Yes, ma'am.
Any other questions that the doctor can answer for you?
Is there any type of pain management for shoulder pain where a shoulder replacement has been suggested and not do the surgery?
Yeah, I just read an article. This is just literally last week it came out. There's this thing, and I talked to your orthopedic about it, but this just came out where they found that short-term relief for any kind of, like, for example, like a rotator cuff tear, certain types of short-term relief can be offered with this thing called PRP, platelet-rich plasma, where they inject it in there, and they found that short term, it offered benefit as far as increasing functionality and reducing pain. So that could be something that could help, but that's something I'd probably talk to the orthopedic guys about and see if they can help. What I don't want for you is where you're constantly getting shots in the muscle and then making the muscle weak. So that's not fair to you either. But PRP was something that I found to be interesting. So you might be a candidate for something like that.
I'll call Dr. Wilson.
Perfect. You're in good hands there. That's perfect.
It's not him, Ryan.
That's right. Either one. They're great. Good people.
Thank you.
Yes, sir.
Right, no more questions? I think that's all of their questions. Did you have anything else that you want to share?
No, I think it's outstanding. I just want you guys to, take care of yourselves. It's been a crazy year. Just be safe out there. And if I can ever be of any service, I'd be honored. Thank you for your time.
Thank you so much for joining us. Next week, we have Rabbi Jeremy Fine. He will be discussing Jewish sports and modern society. And tonight is the 2021 Federation campaign kickoff. So I hope you'll be joining us tonight. We have a pretty amazing speaker, Simone Canigo, and you can join us on the JEA Facebook page live and on the JEA YouTube page. We are going to not do a Zoom event tonight to try to make it easy for everyone to join. So I hope you will join us tonight. And we will see you tonight and see you next week. Thank you everyone for joining.